Welcome all to this particular introductory session for part one. Okay, so we know that there are two papers, paper one and paper two. Paper one will have 100 single based answer questions, and paper two will also have 100 single based answer questions. Okay, now we should know the difference between single based answer questions and the multiple choice questions. The multiple choice questions which we have solved up till now will have generally four options. Out of them, one is correct and three are wrong. But here in RCOG, they are asking single based answer questions in which you may have more than one answer which is correct, but only one will be the best and correct. Okay, so we have to select the best and correct. So when you read the options, sometimes we do get confused. That is what is the importance of SBA. So paper 100 SBS, paper 1 will have 6 modules. This anatomy and embryology module 1 carries 30% of weightage, one third of paper. So we have to devote maximum time for this particular subject. Okay, and most of the time embryology of pharyngeal arches and cardiovascular system development, all these we have forgotten, but these things are asked. Now we are going to go into details of all this, and I'll tell you in subsequent slides which are the concepts that will be asked in the examination. Same thing about physiology pertaining to the pregnancy will be asked. Okay, then biochemistry, again related to the obstetrics and gynecology, they are asking. Endocrinology, very important. I don't know why most of the candidates find it difficult, but it is actually HPO axis, all problems with menstrual disorders, they are asking here. And if we prepare well, including our recalls questions, this is not a difficult. Next is epidemiology and biostatistics. This carries again 12 to 15 maximum weightage, and most of the candidates are worried about this particular, especially biostatistics. But I'll say this is the most easy subject. You attend our biostatistics session when we will be covering 1 month prior to the exam. Okay, generally we keep this session at the end. Okay, because it is little volatile and we cover different types of questions which are asked. So only the values will be different, but it will be something like a mathematics. You apply that particular formula and you get the marks. Okay, so this particular we will be covering at the end, this particular station. Genetics is also important. They are expecting the pedigree and autosomal dominant, autosomal recessive, etc. We will see in each module what is expected by RCOG, so that we will know what exactly is to be studied. Okay. Now coming to the paper 2. Paper 2 will also cover 6 modules, in which there is a pharmacology, microbiology, immunology, biophysics, pathology, and last is a clinical management and data interpretation. Now if you see, this clinical management and data interpretation will have almost 20 to 25% of the weightage, and rest of the things will be around 10 to 15% of the weightage. Okay, so you cannot skip any of the module. Remember, we cannot put any module on the option. You have to prepare all the modules. Okay, the pharmacology, various drugs, right from the oral contraceptives, antibiotics, mechanism of action of antibiotics, how the penicillin acts, how the macrolide group of antibiotics act, where exactly they will act, they are asking. But all these concepts, what they are expecting, we have the list of the concepts, and that we are going to cover. Then microbiology, most of the time they are asking about the infections like vaginal infections, trichomonas vaginalis and all. Immunology, hypersensitivity reactions they are asking. Biophysics, certain concepts are there. Generally these are recalls only. Biophysics, we may or may not have a separate session, but we will cover all the recalls, and that itself will be around 7 to 8 questions will be repeated like that. Then pathology, we will go into the detail because this is also a big subject. And last one is a clinical management and data interpretation. Okay, so this is just a simple question. Dr. Sansi, can you read this particular question? Dr.
A
Sansi?
24,
Yeah,
a
yeah.
24-year, yes, sir. A
Yeah.
24-year-old presents at 27 weeks into her second pregnancy feeling unwell with backache, fever, and rigors. She has a temperature of 39.5 degrees centigrade. Urine analysis shows leukocytes and protein plus. Her blood pressure is 80/15. Which action is most appropriate? admit to ICU or for IV antibiotics and supportive care, arrange ultrasound for renal tract, commence 7-day course of oral antibiotics, give intramuscular steroids to promote fetal lung maturity, make referral for physicians to review. Option A, sir.
Yeah, yeah. See, here this particular case is a case of sepsis. Okay, and this particular case, sepsis, how she is in hypotension, she has got a pyrexia, and there are leukocytes, proteins are plus fever. All this history suggests that she is in sepsis. So the first will be her admission to the ICU and HDU, and IV antibiotics. These are the most important thing. IV antibiotics has to go first, and this particular patient who is hypotensive should be there in ICU and HDU. No doubt, arrange ultrasound. Okay, we are suspecting maybe sepsis secondary to urinary tract infection, so all investigations are required. Okay, but this will come later on. Okay, the first she will be admitted in ICU and HDU, then 7-day course of oral antibiotics. We will not be giving oral antibiotics, so that is why this is not appropriate. Giving intramuscular steroids to improve the lung maturity, again this clinically at this moment this is secondary. Okay, then make a referral for physician's review. This will be there, but primarily she has to be in ICU considering her vital parameters. So that is what they are asking. Okay, so the same thing what we have discussed in our table, how much is the weightage for each subject. Okay, so at least paper 1 and paper 2 idea you must have got. Okay, so from here onwards, we will go into the various concepts which we need to learn. Okay, so we will be having our classes on weekends. I will tell you the time 1 or 2 days before, or maybe at least 1 day before, where exactly our session will be. Mostly Friday, Saturday, or Sunday, because I have got part 2 batch also. I have got part 3 students also. So generally, I need to decide that. Okay, so anterior abdominal wall, they are asking most frequently asked questions around anterior abdominal wall. They are asking about the anatomy, different muscles, external oblique, internal oblique, rectus muscle, actions of this muscle, nerve supply, blood supply. We have got a separate lecture on this. Okay, and all my lectures will cover most of the questions, and all this lecture PowerPoint will be given to you for reading. Okay, then that will help you in the final for revision. Then inguinal canal, femoral canal, hernia, uh, uh, very frequently asked. Now what happens, these things, more detailed anatomy, we are not actually in day-to-day practicing, so we may not be sure, but we are going to cover this along with the questions which are frequently asked. Brachial plexus anatomy, very frequently asked. Okay, relevant injuries they are asking. Anatomy of the pelvis, pelvic diaphragm. This is relatively easy because we have studied this in our specialization course. Okay, then everything related to uterus, tubes, ovary, blood supply, nerve supply. They are also asking about ischiorectal fossa, the fetal skull dimensions they are asking. Then perineum, vulva, vagina, and all obstetrical injuries, anal sphincter injuries they are asking. So basically it comes under anatomy also, and clinical management also. Okay, so these are the questions very frequently asked. Then in embryology they are asking about gametogenesis, fertilization, implantation, including this mitosis, meiosis they are asking. But all these concepts, whatever they are asking, we know, and all these will be covered in our session. Then most important is the first week, second week, and third week of development. The concept of gastrulation, neurulation, somite formation. Development of various organ system, in which we have cardiovascular system, reproductive system, renal tract system, CNS, and GIT development. Okay, so any of the system they can ask. The pharyngeal arches they are asking. Okay, and different derivatives which develop from these arches. Okay, so that is what is frequently asked. Then physiology. In physiology, the acid-base balance, various physiological changes in pregnancy like cardiovascular changes, respiratory system, GIT, etc. Calcium homeostasis they are asking, physiology of labor, menstruation, ovarian cycle, placental physiology, fetal circulation. These are the frequently covered concepts. Okay, Then endocrinology, concept of hypothalamo-pituitary axis, role of hypothalamus, hormones of anterior pituitary, posterior pituitary, thyroid hormones very frequently asked. Not only hormones, but the disorders are also asked. Okay, adrenal hormones are also favorite, and related disorders like Addison's disease, Cushing syndrome, Conn syndrome, pheochromocytoma. Placental hormones they are asking, hormonal control of puberty, menopause. So these are the concepts which come under endocrinology section. The next is a biochemistry section in which the carbohydrate, lipid, protein metabolism, Krebs cycle, ketone bodies formation, amino acid pool, essential, non-essential amino acids, role of proteins, etc. I am sure that you must be getting stressed considering this or listening to this particular Krebs cycle and all, but they don't ask in detail, but certain important steps, the rate limiting enzymes of all these cycles, how many ATPs are produced, where does it happen, whether it happens in the mitochondria, whether it happens in the cytosol, all these things questions are asked. So these concepts we are covering. So now when you listen to this particular talk, you will find it is little difficult or you may feel stressful, but as we go into the live sessions in biochemistry and all, you will find it comparatively easy. Second thing is that our aim is to score above the cutoff. Okay, so and last batch was 100%, and I am sure if you go in a methodical way, you will 100% pass. Glycogen storage diseases, digestion and absorption of macronutrients, urea cycle, vitamins, LFTs and RFTs. These are frequently asked topics from the biochemistry. Then pathology, they are asking about the cell injury, wound healing, neoplasia, coagulation abnormalities, blood transfusion, shock, various obstetrical disorders like preeclampsia, eclampsia, HELP, acute fatty liver of pregnancy, gynecological conditions affecting the genital tract, both benign malignant diseases of the tubes, ovaries, cervix, etc. Pharmacology, around 10 to 12 SPAs are there, in which the drugs which are covered are oxytocics, tocolytic agents, anticonvulsants, anti-epileptics, anti-asthmatics, anti-cancer agents, antibiotics, oral contraceptive pills, drugs used in abortion, teratogenic drugs, anticoagulants, biological agents, and antiretroviral agents. So this is also we are going to cover everything in detail. Biophysics, around 8 to 10, not more than that. They will be asking us about electrosurgery, electrocautery, types of current, sonography. Many questions are asked on the ultrasonography, right from the principles and all. Various special investigations such as CT, MRI, laser, different contrast which are used. Okay, radiotherapy. Not only that, they are asking about the units of measurement. Okay, so we have all these questions. So in this particular session, we will cover that. Genetics is one of the important topic in which they are asking about autosomal dominant recessive, X-linked inheritance pattern, then non-Mendelian inheritance like mitochondrial inheritance, genomic imprinting like Prader-Willi, Angelman syndrome, then prenatal genetic diagnosis and PGT, pre-implantation genetic testing, NIPT, CVS, amnio, and there are guidelines for this. CVS and amnio, RCOG study material is there. So whenever, whatever information will be asked, that will be asked from those particular guidelines. So whatever figures and information is given, the answer should match with those guidelines. So reference will be only RCOG, okay, study material. PGTA, PGTM, PGTSR, chromosomal abnormalities, numerical abnormalities, aneuploidies. So these are the concepts which are covered, and we will go. We have a very good talk on the lecture on genetics. After that, I think above 80% questions you should be able to answer with that. Then microbiology, in which we have group B streptococci, listeriosis, syphilis, torch infection, HIV, Australia antigen, various fetal infections they are asking, like toxoplasmosis, cytomegalovirus infections, and sexually transmitted disease, chlamydia, gonorrhea, etc., etc. Okay, so these are the concepts which are asked in microbiology. Immunology, they are asking about innate immunity, adaptive immunity, components of innate immune system, immunological aspects of pregnancy, then hypersensitivity and immune disorders. Okay, so these are the concepts which they are covering in the immunology. Biostatistics, you will be asked about the different types of tests, types of data, measures of central tendency, measures of dispersion, sensitivity, specificity, and last batch has really done well with this particular, biostatistics. And it is not at all difficult. First thing, if you have any fear about biostatistics, that will go away once we cover this in live session. And second thing is that this I keep 1 month prior, because no doubt it is little volatile. So it's always better to finish it last. Okay. Then data interpretation. Just a moment. I think someone is joining. Uh, yes, Dr. Poonam. Welcome, Dr. Poonam. So next is a data interpretation. So this is a paper 2 we are discussing. In paper 2, we have covered 6 modules in paper 1, 6 modules in paper 2, and we have also covered different types of concepts which are asked in each paper. So in data interpretation, they are asking about interpreting the screening and surveillance data like Down syndrome screening test, okay, combined test, quadruple test, understanding risk in pregnancy, relative risk, odds ratio, absolute risk reduction, etc. ABG analysis questions are there. NST may be given, and you will be asked about the CTG, oxygen dissociation curve, aerodynamics chart they might give, Abgar score, Bishop score, semen analysis report. So these are the reports where they will give you the report, and some diagnosis or some next step of management will be asked. And being a part one, it won't be very, very difficult. Okay, but somehow this particular topic also few students find it difficult. But for those who are practicing obstetrics and gynecology, I feel maybe we might not be practicing much about urodynamics, so we may find it little difficult in interpreting these particular charts. But we are going to cover each and everything. Like for ABG, we will have a session, and they are asking to identify the condition, whether it is metabolic acidosis, that is metabolic alkalosis, and all. That's all. So I think this should also be an easy session for you. So these are the different books which are available, and soft copies I have provided to all of you. Dr. Prachi, you have received this particular books by email. Hello.
Hello.
You received these books I have sent
Yes,
by.
sir.
Yeah, yeah.
Yes, sir.
Yeah. So out of which this particular book is going to be very, very important, and the rest of the books are SPA books. Okay, and these are two are your Bible, Quran, Bhagavad Gita. These two books. Okay, this Oxford revision notes, and this is the MRCOG part 1 book, and these are all practice books. Okay, so
Okay.
whenever you're free, just solve these from soft copies. I won't suggest you to make the hard copies unnecessarily. It will increase the burden to carry and all. In final, you have to revise last in 2-3 days. Okay. So there are certain do's and don'ts. Start preparation with positive attitude. Then collect all resources and keep it organized. I have already given you it in an organized manner. Okay, you need to have your own schedule, because few are the candidates who are doing their residency. They are 24/7. They will be working. Then few are specialists. We have our practice, we have our family commitments, but along with that we have to do this. Okay, and it is feasible. And I'll say for part 1, how much time you give? Not more than 15 minutes per day, and weekend you give maximum 1.5 to 2 hours in the beginning on weekends for our live classes. That's all. And at the end we will give 1 hour almost daily, plus 3 to 4 hours you have to study on your own, maybe last 1 month. Okay, then you need to revise all SBS 3 times. Then what we are not supposed to do, don't wait till last day for the booking the examination. The most important thing, by this time what you should have, one, all of you should have your RCOG number, account created. Second, you should have sent the application for eligibility, and third, you should have sent the expression of interest. Dr. Sansi, have you sent the expression of interest for the examination for January 2026? Sansi, you are there?
No, sir.
Now,
Yes,
okay.
sir. No, sir.
Yeah,
You sent it, sir.
yeah, you do send now itself, because whosoever will send the expression of interest, only those candidates will get an email giving some token, and you are booking, when the booking window opens, you have to put that token. You got it? That is why this particular sending the expression of interest is important. That we have to do now itself, because it has got a deadline. After that, you cannot send also, and then you will not be eligible for January 26. Okay. So rest of the things, I think you have, Dr. Sansi, you have done that. You have got RCOG account. You have also confirmed your eligibility. Dr. Pachi has applied for the eligibility. Okay, but you will get confirmation in 1 month. If your documents are correct, no doubt, it is confirmed that you will get the eligibility. Okay. So these are the few things which you should not, don't take this particular thing lightly, because you will find, suppose tomorrow is a 14th of August and the window for booking is opening at 2 o'clock in the afternoon. By 2:30, all the seats might be blocked. Okay, so your exam, you want to appear in Pune, you may not get the center in the Pune, because all Pune centers are booked. Okay, so if they have given the time, the booking window will open on such and such date and such time, then you will log in at that time with your credit card ready and book your exam within 10 to 15 minutes of the starting of that particular time. Okay, then you will get the center of your choice near to your house, and we have to do this examination from our house, from our free time. Okay, then how to study? Okay, try to get used to the e-learning. Try to get used to the soft copies which are available. Okay, and follow schedule and study module wise. Okay, don't study haphazardly. In your clinics, whenever you are sitting, no, at that time, in free time, you can solve couple of SBS. Then also go module wise. Okay, more time for modules with high percentage. We have already discussed maximum weightage is given to anatomy embryology, so we'll spend more time for anatomy embryology. Same for data interpretation and other few modules. Then prepare your own notes. So even if I am covering this concepts in our live session, you need to have your separate notebook in which you will be writing down your own notes. It will help you for final revision. Then complete the task, if whatever the task which I'll give you. Then live session on weekend, you need to attend all live session. By any chance, if you are not able to attend, then listen to this particular audio, because I will be giving you the link to the this particular live session. Okay, then question bank from the website. Then give time for the revision. This revision is going to be very, very important, especially in the last 1 month. Then concentrate on recalls. We have got recalls of the almost last 7-8 years, but at least 3 to 5 years recall we are going to cover. Okay, then last 1 to 2 months, at least 2 to 3 hours per day you have to study and attempt. I'll be posting some questions in the group that you need to attend. Okay, tips and tricks, like you have to study. Study is the most important thing. You can use the mnemonics, recalls, exam wall. Consistency and persistence is required. Okay, these are certain advantages and disadvantages. Okay, the key to success is organize your study material, have your own schedule. You need to practice SBH. The consistency and persistence is required. Most important is your positive attitude will lead to the success. Do not stop till you achieve your goal. Okay, understand the technique of each part is different. Okay, so part one I am discussing now, because the technique is a computer based examination, SBA type of question. Part two, question type is also different, so the way of preparation is also different. So you cannot use the same technique of preparation for different parts. Okay, then dedication and determination is required. Have your own notes and adequate time for the revisions. This is the way the exam wall looks like. Everyone, even at this stage, we are working as a consultant. Then also we need to prepare the note, put it like this, and it will help your examination well. Okay, so that covers about the introduction part. Any of you have questions regarding this paper one, paper two, the various concepts which I discussed, how to go ahead? Ask now, then we can have a small session on nausea and vomiting in pregnancy. Okay, anything you want to ask?
No, sir.
Sir, can you tell us how to give expression of interest in short? if possible.
Yes. Actually, expression of interest. No, you go onto the website and go into the part one. It will be under the heading of careers and training. Okay. So in the career and training, you click on part one. In part one, you will get. They will ask you about the application for eligibility. Send an expression of interest. Okay, like that. Or there will be search option on the website, so just put expression of interest. Okay, then you will get that particular page directly. Okay, and you just have to put RCOG number, and that's all. A minor form is there sending the expression of interest. Okay, that you will be able to do, or I can guide you while doing also. That is not a problem. Okay. Anything else? If you have any query regarding whether it is possible, how to do any queries which I have not discussed, you can ask, no problem. Okay. And this is just another 20-minute session. We will cover management of nausea and vomiting in pregnancy. Okay. Shall I go ahead with the session now?
Yes, sir.
Yeah. So this topic is from the clinical management. Another thing which I forgot to tell you, generally I start my part one preparation with anatomy, embryology, etc. But now currently the series for the part two is going on. There are certain common topics. Okay, like antenatal care, in which basic things they are asking, like pregnancy induced hypertension, gestational diabetes mellitus. They are asking about this nausea, vomiting in pregnancy. Okay, so the same link I'll be giving you in next 2 weeks. So we will cover the clinical management part of these basic obstetric topics, and after that maybe this month end or first week we are going to start with the anatomy, embryology, and by this time we will have finished last three sessions of the clinical management. Okay, so it will help us to finish our curriculum by the end of the November, or maximum December first week. We are going to cover all these 12 modules. December complete, we are going to do the revision, and I think your exam is on 14th of January most probably. So 1.5 month we are going to get for the revision, and that time we may have to sit alternate day also. Okay, so you should be ready from that particular point of view. Okay, and daily from this particular month end, once we start with the anatomy, physiology, I'll be posting some kind of video, may not be prepared by me, but some kind of concept which will be there. I'll be posting that. Please watch that video, understand the concept. So 4 to 5 days I'll be putting some concept related video. You have to listen to that video. It won't be more than 10 to 15 minutes, that video. And at the end of the week we will have the live session. Okay, and that will be taken by me completely. So we'll start with our session, the management of nausea, vomiting in pregnancy, and hyperemesis gravidum. This is the green top guideline number 69. Okay, so this nausea, vomiting in pregnancy, and hyperemesis gravidarum, this is classified. There are two indices which are used. One is a pregnancy unit quantification of emesis, PUQE, and another is a HELP. Okay, that is hyperemesis level prediction. These two words you should remember: PUQE and HELP. So these are the scores which are used for classification, severity classification. Okay, so there can be SBA. Following are the scores which are used, and they may give 3-4 different scores, and one of the score may be this or this. Okay. Then ketonuria is not an indicator of dehydration and should not be used to assess the severity. First line antiemetics such as antihistaminic, thiazines, doxylamine, pyridoxine, etc. These are the first line antiemetics which are used. Then ondansetron is a safe. This is a second line drug. Ondansetron is a second line. First line is covers antihistaminics, phenothiazines, and doxylamine and pyridoxine. Then second line we have ondansetron. If the first line are failing, then we'll go for second line. There is a small increase in the absolute risk of orofacial clefting. So they can ask you about the side effect of ondansetron. It can be orofacial clefting with ondansetron using the. So we have to balance the risk with the poorly managed hyperemesis. That is why they are putting this as a second line. Okay. Then metoclopramide side effect is extrapyramidal effect. It has to be given slow injection by over a period of 3 minutes. Sometimes they may ask you the second line drug, and they can give you metoclopramide as one option, and metoclopramide given slowly over a period of 3 minutes. So the first option you look at metoclopramide, you may give select that, but select the option metoclopramide given slowly over a period of 3 minutes. That is going to be the best answer. Did you get it, what I mean to say? Because they are asking for the best answer. Okay. Then coming to the fluid, the normal saline 0.9% with additional KCl in each bag with administration which is guided daily by monitoring of the electrolytes. That is the most important fluid which is used. Then what is the prevalence? They are asking about this figure. How many, what is the prevalence of nausea vomiting in pregnancy? 90% of the pregnant women have the nausea and vomiting in pregnancy, and generally typical hospital stay is for 3 to 4 days. The nausea vomiting in pregnancy is defined as symptoms of nausea and vomiting during pregnancy when the onset is prior to the 16 weeks of gestation, where there are no other causes. So onset is typical, and that is how we differentiate it from other causes of nausea and vomiting. Hyperemesis gravidarum is a severe form of nausea and vomiting which affects between 0.3 to 3.6%. Okay, so hyperemesis is different and nausea vomiting of pregnancy is different. This is a common condition affecting 90% of pregnant women. This is uncommon condition, hyperemesis gravidarum, more severe form, and only 0.3 to 3.6% of pregnant women are affected. Okay, so this affects the quality of life, inability to eat and drink normally. What is the mechanism of action? The hypersensitivity to vomiting hormone growth differentiation factor, that is 15 GDF, that is the proposed etiology. Okay, hypersensitivity to vomiting hormone growth differentiation factor. This GDF 15 causes loss of appetite, taste aversion, nausea, vomiting, weight loss, etc. Hyperemesis gravidarum can be diagnosed when symptoms start early in pregnancy. Nausea and vomiting are severe enough to cause inability to eat and drink normally, strongly limits the daily activities of living, and signs of dehydration are contributed to the diagnosis. So, actually, this particular guideline is updated recently. If you read the previous guideline, lot of weightage was given to the weight loss and electrolyte imbalance, etc. But now the guideline says more about the quality of life, that is inability to eat and drink normally, etc., etc. So that is what is little difference in the guideline. Okay, so what are the scores which I have discussed? One is a PUQE score, which can be used to determine whether nausea vomiting pregnancy is mild, moderate or severe. The PUQE score can be used to assess the response to the treatment for mild to moderate nausea and vomiting, but it is not valid for severe nausea, vomiting on pregnancy and hyperemesis gravidarum. Remember, this PUQE score, pregnancy unique quantification of MSS score, is applicable for nausea vomiting in pregnancy for mild to moderate cases, but not for the severe one. Okay, while the HELP score, okay, hyperemesis level prediction, it can quantify hyperemesis gravidarum symptoms into score that can be trended over a period of time to monitor the progress and response to the treatment. So this can be used for all, and it can also monitor the response to the treatment also. The nausea vomiting in pregnancy and hyperemesis gravidarum, this is another question which they are asking. What is the electrolyte imbalance in the nausea vomiting or hyperemesis? There is a hyponatremia, hypokalemia, low serum urea, and raised hematocrit and ketonuria, leading to the metabolic hypochloremic alkalosis. So they ask you the following changes seen, electrolyte imbalance is seen in hyperemesis gravidarum. It is hyponatremia, sodium is reduced, potassium is reduced, urea is reduced, but this hemoconcentration is there. Okay, and ketonuria is also there. Most of the students get confused what happens to the urea. Urea, does it increase? But if you read the guideline, it mentions there is a low serum urea. Okay, especially when in early stages, unless there is an acute injury to the kidney. Okay, if severe, then there will be metabolic acidosis, and otherwise the common is a metabolic hypochloremic alkalosis. So this is also a question. What is the metabolic change? It is a metabolic hypochloremic alkalosis. This is a question. Okay. In 2/3 of women with hypertension, there may be abnormal thyroid function test. So this is also a single based answer question. How many percentages of female with hyperemesis gravidarum will have abnormal thyroid function test? 2/3 of the patients. Okay, almost 67% of the patient. There will be rise in the T4 level and TSH will be low. However, it does not require a treatment in a straightforward nausea vomiting in pregnancy where the cause is clear and the patient is responding to the treatment. So no treatment is required for abnormal thyroid function test even if the T4 is raised and TSH is low. If the cause is nausea vomiting or the hyperemesis is the cause, you correct the hyperemesis gravidum, automatically this gets corrected. Okay, and they give you the clinical question where the patient especially in data interpretation. Okay, they will give you the condition, the patient has got hyperemesis gravidum, these are the values of TSH and T4 and all, and what kind of treatment will you propose? The option will be no treatment required. This is a gestational hyperthyroidism. Okay, then liver function tests are abnormal in 40% of cases. The most likely is a rise in transaminases. So these thyroids are abnormal in 2/3 of cases or 67% of cases, and LFTs are abnormal in 40% of cases. Remember these two figures. Okay, then how should women with nausea vomiting, they should be cared for? There are different types of care. Okay, the first is a community care, second is a ambulatory care, and third is a inpatient care. So these are the different types of care. So they RCOG wants you to know which patients you can give what kind of care. So mild to moderate patients can be managed in the community. Then if the community measures fail, then you go for ambulatory day care. Then if the patient cannot be managed in ambulatory, then go for inpatient. Okay, so if there is a what are the indications for inpatient care? Continued nausea and vomiting if the patient is unable to take down with oral antiemetics. So patient is not responding to oral antiemetics. There is a clinical dehydration or weight loss more than 5% body weight. Confirm or suspected comorbidity like UTI, inability to tolerate oral antibiotics, etc. There is a comorbidity like epilepsy, diabetes, etc. So any other medical disorder is associated for which she is taking the medicine, and because of hyperemesis, she cannot tolerate the medicine, and otherwise there is a risk that this particular condition will get worsened. So we need to hospitalize this patient for that particular purpose. Okay, so you need to understand the indication for inpatient care. So in the scenario, they may give you either of this particular thing and will ask you what kind of care, whether she will be managed in the community or ambulatory or inpatient. So these patients will require inpatient care. Okay, is this clear? Is it clear to all of you? Yes.
Yes, sir.
Yeah, good. Okay, so next, when there is no response to single antiemetic, what we do, we use combination of the drugs. Only licensed drug for treatment of nausea vomiting in pregnancy is a delayed release combination of doxylamine plus pyridoxine. This is the only licensed drug. Okay, this is the first line treatment for mild to moderate nausea and vomiting. For women with persistent or severe hyperemesis gravidum, we use parenteral, transdermal, or rectal use. Then if the patient is still not responding, we go for corticosteroids. It is reserved for severe cases. Okay, so initial treatment is IV hydrocortisone 100 milligram BD, then we convert it to oral prednisolone. So these details are not asked for part 1. Okay, but just remember the third line is corticosteroids initially given IV followed by oral. That oral also we need to taper it. Okay, we don't stop any steroids abruptly, we taper it. Okay, so coming to the drugs, first line we have discussed antihistaminics, phenothiazines, pyridoxine, doxylamine, etc., etc. Then second line we have ondansetron and metoclopramide. Metoclopramide we discuss about the extrapyramidal side effects, and ondansetron we discuss about the orofacial clefting. Now this orofacial clefting, if you see with the ondansetron, what do they say? It should be balanced. The risk should be balanced with the with respect to the poorly managed hyperemesis gravidarum. And what is the risk? 11 per 10,000 cases to 14 per 10,000 cases. So this is very small. This is actually the risk, very minor risk. 11 per 10,000 to 14 per 10,000 birth with ondansetron. Then metoclopramide can also be used, and because of the risk of extrapyramidal side effects, it has to be given slowly over a period of 3 minutes. Okay, that we have discussed. Then adverse effects, nausea, vomiting in pregnancy. associated with electrolyte imbalances, urea electrolyte we have to measure daily. Then recurrent intractable vomiting may lead to gastroesophageal reflux disease or esophagitis, gastritis. What measure we will do? We'll give antihistamine, histamine type 2 receptor blockers or proton pump inhibitors can be used. Okay. Then nausea vomiting can lead to wernicke's encephalopathy due to vitamin B1 deficiency. So thiamine supplementation is required. Okay, so we have to give this either orally 100 milligram TDS. The doses are not asked. They will ask you what deficiency can lead to this wernicke's encephalopathy, and this is very common when you use the 5% dextrose. So 5% dextrose is not at all a preferred fluid. The preferred fluid is a normal saline with addition of KCl. Okay, 0.9% saline. GRD treatment, add proton pump inhibitor along with antiemetics. Okay. Then what are the further things? Women with hyperemia have increased risk of venous thromboembolism. Risk is high because of the dehydration. Okay, so these will be required whenever they get admitted. We have to give low molecular weight heparin. Okay, oral iron can lead to the nausea and vomiting, so we don't start oral iron therapy in the first trimester. Okay, not only that, another important thing about the ondansetron is it causes constipation. So whenever you give ondansetron, we need to offer laxatives if the patient is constipated, particularly if the ondansetron is used. So with respect to ondansetron, extrapyramidal side effects and the laxatives, these two things you remember. So these things will not be asked from you in the part 1, so I'll skip this. But wernicke's encephalopathy, remember, vitamin B1 deficiency. Okay, they can ask you about this last line. Almost 1/3 of the women will be readmitted within the same pregnancy. Okay, so if the patient is having hyperemesis gravidarum, what is the chance that she will get readmitted? There is a 1/3 chance again that she will get readmitted. Okay, so parenteral and tube feedings will not be asked, so that is not for you. But optimal rehydration, this will be asked. Normal saline 0.9% with addition of KCl in each bag with administration guided by daily monitoring of electrolytes. So this is the complete answer. What is the fluid of choice? Normal saline 0.9% with addition of KCl in each bag with administration guided by the daily monitoring of the electrolytes is the fluid of choice. Use of dextrose infusion for fluid replacement is not recommended. It may precipitate wernicke's encephalopathy in thiamine deficient patient. This we have just seen. Okay, so these are the concepts which they are asking. Then when to terminate the pregnancy? Higher risk of termination. Almost 10% of the patients with hyperemesis gravidarum will go for termination of pregnancy. So when all treatment options like antiemetics, corticosteroids, enteral, parenteral, everything is over, then you have to do the multidisciplinary management. You have to take, do the psychiatric opinion also if there are any concerns regarding the mental health, and then you document the failure of all medications, and then you decide for the termination. Okay, then what is the long-term effects? Risk of who experience hyperemesis have increased risk of postnatal depression, anxiety, PTSD, post-traumatic stress disorder. Sometimes they can ask you what is the risk in the postpartum period. So they have got a risk for postnatal depression, anxiety, postpartum, post-traumatic stress disorder in this period. Risk of recurrence in future pregnancies very wide range, 15 to 80% risk. Okay, and that is why for these patients you can early before they develop the symptoms, you can start with antiemetics. So this is a PUQE course index. Don't worry about this, they will not ask you this index, but what you have to remember, one is a name, pregnancy unique quantification of emesis. This score is called as PUQE 24 score. This 24 score does not mean the total score. The total score is 15 only. This 24 stands for 24 hours. We are measuring this score in the last 24 hours. Like in the last 24 hours, how long she felt that nauseated, sick, or to her stomach. And then it is given some score. That is why it is called as PUQE 24 score. Okay. Then mild is 6. Yes, these are asked. What is mild, moderate, and severe? Severe is 13 onwards. Okay. Total is 15. 13 onwards is severe. Mild is up to 6 and moderate is 7 to 12. Okay, so this much you should remember. Okay, then HELP score, hyperemesis level prediction. Here these are the ranges, cutoffs. Mild is 19 or less than 19 is mild, 20 to 32 is moderate, and 33 onwards up to 60 is severe. So total score is a 60 here. Okay. So you don't have to remember all these things, but just remember HELP has got a total score of 60, mild, moderate, severe, and the cutoffs. Okay. So these are the medicines. Again, the doses they are not expecting from you. Only you should know which drug, first line, second line, okay, and third line. Third line are the steroids. Okay. So these are the investigations, same investigations what we carry out routinely. And this is what is the final flow chart in which they are saying which patients are to be managed in the community. Then you have ambulatory management, and then you have inpatient management. Okay. Whenever these inpatients, you have to look into the red flag. Okay. So which patients, if the patient has got red flag, the patient directly goes for inpatient. So whenever in the question or the exam, if you are given a scenario and that scenario has got any red flag sign, like any score with complication, patient has got some complication, or inability to tolerate oral intake, or unresponsive to OPD management, clinical dehydration, or if there is a weight loss more than 5%, confirm or suspected comorbidity, like patient has got UTI, diabetes, comorbidity, and unable to take medication, she is a known cause of epilepsy. These are all we have discussed. These patients directly go for indoor management. Okay. While which patients can be managed in the community? Mild to moderate cases of nausea and vomiting. You just have to give support, reassurance, oral hydration, offer dietary advice, consider use of laxative if required, prescribe histamine type 2 receptor blockers or proton pump inhibitors, and some you have to do the mental health assessment. You reassess after 24 to 47 hours, and if there is a minimal or no improvement, you can add. So next step will be addition of antiemetic. Okay. Then when up titrating, add drugs as opposed to the replacing them. So don't stop the previous drug, you continue with the first drug plus add the second drug. Okay. And if still not getting control, then the patient goes for the this inpatient management. Now which patients are for ambulatory this thing, where the PUQV score is 13 or more with no complications, inability to tolerate oral intake, and community measures have failed. Okay. This PUQV score we have seen here. Okay. So the score is high, 13 or more, but there are no associated complications. The patient is in the ambulatory care. Okay. Remember here PUQE score. So just don't look at this particular score and decide that it is a severe category, and that is why she should be. This score with complication is inpatient management. Only score of 13 is ambulatory management. Okay. They don't want to burden the hospital because the services are free in the NHS. So they don't want to burden unnecessarily. That is why they are very particular about these protocols. Okay. So that finishes the topic of hyperemesis gravidarum. I hope you have understood these particular basic things. Have you understood, Dr. Sansi, Dr. Patil?
Yes, sir.
Yeah. Okay. Actually, I have. If you have time, I can cover a few questions also, so that you will get idea how what type of questions. 5 to 10 minutes. Can we continue more?
Yes, sir. We can continue.
Yeah. Just a moment. I'll. Uh, Dr. Sansi is there.
Oh, sir, I think she has left.
So most probably she must be on duty or something like that. You want to try this question, doctor?
Yes, sir.
Yeah. Read this question loudly and just tell me the answer, doctor.
I'm not able to see the screen.
You are not able to just a moment. Now, can you see the now?
Yes, sir.
Yeah, just read this question.
A 28-year-old woman at 9 weeks of gestation is admitted with hyperemesis gravidarum, requiring intravenous hydration and antiemetics. She is dehydrated with normal sodium and low potassium levels on admission bloods. You decide to start IV fluids and antiemetics. Which of the following is the most appropriate initial management for intravenous hydration and antiemetic therapy in this patient? Option A, 5% dextrose infusion with metoclopramide rapid IV bolus. B, zero point 0.9 normal saline with potassium chloride guided by daily electrolytes and metoclopramide slow IV bolus. C, Ringer's lactate with ondansetron as the first line antiemetic. D, 5% dextrose with additional magnesium sulfate and chlorpromazine ion. And E, 0.4, 45% saline with glucose with promethazine as the first line antiemetic. Sir, option B.
Absolutely correct, doctor. Absolutely correct. But I'll tell you in the RCOG how they confuse. They'll give you one option 0.9% this, and with metoclopramide IV. Okay. Then they will give another option that will include only slow IV bolus. Okay. So you have to read carefully all options and then select appropriately. Okay. So that is just this particular. So this your answer is absolutely correct. Okay, option why this is we will not go. Just try this question also. Similar question.
A 27-year-old woman at 9 weeks of gestation presents with severe nausea and vomiting. She is unable to tolerate oral intake, reports reduced urine output, and feels dizzy on standing. Examination shows tachycardia and dry mucous membrane. Which of the following features best differentiates hyperemesis gravidarum from nausea vomiting of pregnancy? On option A, onset before 16 weeks of gestation. B, presence of nausea and vomiting. C, inability to eat and drink normally with the interference in daily activities. D, nausea associated with vomiting. And E, associated with fetal gender. This is option C.
Correct. Actually, in my lecture, I told you that older definition was not actually dependent on this quality of life and all, but this new guideline is very much dependent on this quality of life. That is why inability to eat, drink normally with interference uh, in daily activities is the correct answer. Okay. So that is what. Just try this one also. Simple questions are there. We'll
A
give one or two
26 year
questions, then we'll stop. Yeah.
Okay. A 26-year-old woman at 9 weeks of gestation attains the antenatal clinic and asked how common nausea and vomiting are during pregnancy. Which of the following best represents the appropriate percentage of a pregnant woman who experiences nausea and or vomiting during pregnancy? A 10%, B 25, C 50, D 70, and E 90. So it's E 90.
Absolutely correct. Again, here what happens, if you read the older guideline, the value was 80%, and recently they have changed the guideline in which, so even if you have 80% and 90%, the one who has read the older guideline, that person will go wrong. And this is the newer guideline which says 90%. I don't know why, but they ask these numericals. Okay. And
Okay.
another thing is that hyperemesis gravidum, the prevalence is very low. Okay, 0.3 to
0.30.
3.6. Okay, so that is what is the question. Just we'll finish with this last question. Okay.
Okay. A 25-year-old woman at 9 weeks gestation is admitted with hyperemesis gravidarum. She has persistent vomiting, dehydration, and ketonuria. Blood tests are performed as a part of her initial assessment. Which of the following laboratory findings is most likely to be seen in this patient with hyperemesis gravidarum? Hyponatremia with low serum urea and raised hematocrit, hypernatremia with raised serum urea and low hematocrit, hyperkalemia with hypochloremic metabolic acidosis, D, low T4 with raised TSH requiring treatment with levothyroxine, and E, liver transaminases are raised in over 70% of the women with hyperemesis. Uh, so it's A.
Yes, A is correct. And basically, I went into the details, and if you listen my lectures carefully, I generally say that this is asked, this is asked. Those are the frequently asked concepts in the examination. So concentrate on that. And here it is hyponatremia and low seruria and risk. Okay, so that is the best. Rest of the parameters are not fitting into this. Okay, and another thing is thyroid abnormalities are seen in 2/3 of cases, that is 67% of patients, and LFTs are abnormal in 40% of cases. Okay, sometimes they ask these numericals. I don't know why they ask these numericals, but they are fond of asking some numericals. But if you listen to my lectures, automatically it will be in your ears. See, up to 67% of women will have abnormal this particular thing, TFTs, and LFTs will be abnormal in 40. We get confused between the two. Okay, so
Yes,
just this last question.
okay. A 28-year-old woman is admitted with hyperemesis gravidarum at 10 weeks gestation. Blood tests show elevated transaminases. Approximately what percentage of women with hyperemesis gravidarum are found to have abnormal liver function test? It's 10%, 25, 40, 60, and 80. So I don't know, but I'm just guessing it's 40.
Yeah, it is 40. It is 40. Yeah, 67% with for thyroid, 40% for the LFTs. Okay, we'll stop here, doctor. Okay, and one few things. Keep watch on your Telegram. Okay, this Telegram activities I will start by the end of this particular month, because currently proper obstetric topics are going on. So if you listen to my videos, that will be more than sufficient currently. Okay, but when the anatomy, physiology, biochemistry will start, no, at that time we have to be little vigilant. We have to be very particular to understand daily one concepts. Okay, and take down your notes and all. That's all. It's a relatively easy exam, doctor. Okay, don't
Yes.
worry
Okay.
much. Okay, thank you. And I teach for a single candidate also, because other Sansi and all those things. Sansi is little, she's doing her residency, and they have a lot of work. She's the first batch student, first year student, but she is very much interested into this. And we have our other responsibilities. So what happens when I say that there is a lecture, by any chance if you are not able to attend, no, let me also know. Then I can reschedule, or I will unblock my time. Okay, is that fine?
Okay. Yes, sir.
Yeah.
We'll let you know.
Okay. Yeah, thank you all. Chalo, bye.
Thank you so much. Thank you, sir.